Good evening. Welcome to the June 12th, 2013 meeting of the Washington Township Healthcare District Board of Directors. If you'll join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Colleen, can you call the roll?
Director Nicholson.
Present.
Director Wallace. Director Stewart.
Present.
Director Ethan.
Present.
Director Danielson.
Present.
Very good. At this point, I'm going to take the chair's prerogative and take an agenda item out of order, and that is going to be our first action item, which is resolution number 1133, collaborative relationship with academic teaching hospital. And we'll start off with Dr. Stewart making the motion.
Mr. President, Washington Township Healthcare District and the University of California, San Francisco, otherwise known as UCSF, desire to improve the health care of the residents of our community by adopting a shared vision which allows for collaboration between the district and UCSF, yet maintains the independent governance of the district. The intent of the collaborative relationship is to create over time a comprehensive, sustainable, and integrated healthcare network to serve the needs of the residents of the district now and in the future. I move for the adoption of Resolution 1133, which authorizes and directs the Chief Executive Officer to take any and all further actions necessary, which in the determination of the Chief Executive Officer incorporate the substantive intent of this resolution, and to perform any and all other actions contemplated by this resolution, including but not limited to the execution on behalf of the district of agreements between the district and UCSF.
Thank you, Dr. Stewart. Do we have a second?
Second.
We have a second from Director Danielson. Nancy, would you like to?
Yes, I would. Thank you very much. Tonight is a very big evening for Washington Township Healthcare District. It is the culmination of many months of intense discussion with the representatives of UCSF Medical Center who are here this evening. In our audience is Dr. Sam Hawgood, Dean of the School of Medicine, and Mr. Mark Larrett, the Chief Executive Officer of the University of California, San Francisco Medical Center. We have placed before you for consideration this resolution because we believe that our two institutions can formulate a visionary and innovative partnership, linking our two institutions with the potential for others to join us in a continuum of care that will benefit the residents of our district as well as the community at large beyond Washington Township. It's very evident that the world around us in healthcare is changing. And not all of those changes are going to be easy for a hospital the size of Washington Township to respond to alone. It is very clear to me that we need to be part of a larger network in order to embrace these changes and be relevant to our community. This important strategic alignment with UC San Francisco will provide us with that opportunity. Affiliation with an academic teaching hospital has been identified as a strategic initiative in our strategic plans since the very early 1980s. So in many regards, this is the culmination of successive strategic plans. I want to be clear that this is not a merger or an acquisition. Our hospital will retain its independent identity. It is an affiliation through which we can accomplish many important things, but it's also terribly important to the leadership of Washington Hospital that we remain a district and serve our community. This collaboration does pave the way for any number of means of expanded access to specialized physicians the potential to have clinical training programs here at our hospital for medical students and perhaps someday down the road, house staff. One of the very interesting aspects of this partnership is that we both share the same electronic medical record. There are some months ahead of us in going live, so to speak, and tonight the board will hear more about that here at Washington Hospital, but we're on schedule to turn the Epic electronic health record on at midnight on June 30th, just a few weeks from now. When we share that same electronic health record, it will facilitate the transfer of information between the two institutions that will serve to benefit patients and improve all aspects of their care and safety. We think this relationship is going to help us navigate the changing healthcare environment more effectively by creating the ability to leverage with a larger scale and to bring new services to our community. It will give us a chance to have a seat at the table, where I believe were we to remain independent and alone, that we wouldn't even be invited to the table. The emphasis of the Affordable Care Act is to create regional systems. And of all the opportunities that we have, I felt this was the strongest and provided the best opportunity for our institution. I would like to invite both Mr. Laird and Dr. Hawgood to make remarks to the board.
Thank you very much. I'm Mark Laird, the CEO of UCSF Medical Center. First, let me begin by congratulating all of you and the team here, led by Nancy, for the incredible work that you have done serving this community for so many years. This Washington Township Hospital is a source of pride, I think, to all of us in the region, and you should be very proud of the terrific work you have done and you continue to do. At UCSF, we would just echo the comments that your CEO just made. We see a very changing healthcare environment, one that's putting more and more emphasis on collaboration and integration, cooperation. There's much more pressure for us to look at ways that we can come together as providers, maybe with health plans, to provide systems of care to employers throughout the region, all with the idea of doing it at lower cost, better quality, better access, and thus contributing to the improvement of the healthcare system nationally, but also making it better for the residents of this district as well as throughout the Bay Area. I was telling Nancy before the meeting that when Dean Hawgood and I discussed this on Monday night with the clinical department chairs at UCSF, they were universally thrilled that we were at this point. And I think that captures the feeling of all of us at UCSF, is that we see the UCSF relationship with Washington as an anchor to begin the development of a regional accountable care organization that we think could certainly rival and maybe in many ways be superior to what Kaiser offers throughout this region by linking the best hospitals, great physician groups, and offering unique access and quality that may not be available elsewhere. So we're extremely bullish on the relationship and on the prospects for our future. So before I could go on and on about this all night because we're so proud of this relationship, but let me conclude my remarks and introduce the Dean of the Medical School, Dr. Sam Hawgood, who happens to be a pediatrician and neonatologist himself. Dr. Hawgood.
Thank you, Mark. And I would just echo to the board how pleased I am to be here. I participated, I think, in the very first meeting we had. Nancy said a few months ago. It feels a little longer than that, but what I do when we're beginning a partnership is really try to assess whether there is a good cultural fit, whether we share the same kind of values, whether we are trying to do the same value added for our patients who we serve. And I felt extremely comfortable working with the team down here from day one, that culturally and from a values perspective, we were going to be a very good fit, and then felt good that it was simply a matter of working through some of the business issues to get to where we are tonight. So I would echo Mark's comments that I think this situates both organizations well for the future. There's no question the next 1 or 2 years are going to be quite tumultuous. I don't think any one of us know exactly what to expect, but I think scale is unquestionably going to be important. And having partners that we can respect and trust to get through those tumultuous times is very key to me. As part of my role as the Dean, I am president of our medical group, and I would echo Mark's comments that our clinical chairs and clinical faculty see this as an enormous opportunity to create mutually respectful partnerships with your own medical staff, to identify areas where we can be helpful and supportive, and identify areas where you can help our clinical programs, but also, as Nancy mentioned, our training programs. We've had medical students coming down here for a little while, and we get tremendously positive feedback already. So thank you, and I look forward to the next months and years to come.
Great. Thank you very much, Dr. Hoggood, and thank you, Mr. Larratt, for your kind remarks. I'd like to open this up to board members for comment. Pat, would you like to start?
I get to break the ice.
Yeah.
Obviously, I'm very excited about this, and I'm very pleased with this new relationship. Thank you for coming all the way down here from San Francisco. I'm very, very, very excited about this. This is a great new relationship. I had to write all this down so I wouldn't get too nervous and forget about it. It benefits Washington Township Hospital District while we remain independent and retain our individual identity. And for me, that's quite important. One of the reasons that I'm pleased with this relationship is it makes unique, specialized care available to our residents. While I would like to think that we can provide everything, that's just not possible. A number of years ago, I needed some very specialized care, and fortunately, one of our community physicians, who is a member of our medical staff, sent me to UCSF. And that care that I received was not available anywhere else in the Bay Area. It was that specialized. I might add that I received excellent care with a very good outcome. Thank you. Now, as a member of our district board, I am personally pleased with this new relationship with UCSF, who have an excellent reputation, and it will make care for our residents even more accessible than it has been in the past. As a member of the health information management profession, I've spent my career dealing with challenges of distribution of the needed information, health information for patients. First, the medical record has to be located, and that could be off-site. Second, and it may be in a secured site somewhere else, so that may take time, copied, and then given to the patient or the physician and hand-carried to the physician so he can evaluate that information so that he can properly care for the patient. All of this takes very valuable time. A paper system usually generates a great number of pages of paper. Our hospital district is beginning to move forward toward an electronic record system from the same company that you are using. So I'm very excited by that, because that means that the needed medical information can be electronically sent via secured methods and made quickly available to the UCSF specialist. The patient will greatly benefit with this faster and easier system. Since the UCSF physicians are familiar with the electronic medical record system, they will be able to locate the needed information more quickly, and the outcome of this benefit should greatly improve the care of our district patients will receive. I want to give a big thank you to all of the staff on both Washington Hospital and UCSF who work so hard on behalf of our district residents. This is an excellent example of how we are meeting the mission of our district. Thank
Pat.
you.
Thank you, Pat. Jacob?
I think it's a great milestone for the hospital. I'm a practicing pediatrician here, and I tell some of my patients every day that you're so lucky to be surrounded by some of the best children's hospital or academic institutions around, UCSF, Stanford, Oakland Children's. And then the next step, to have a collaboration with one of the top academic institutions. I think there's nothing better than that. I mean, UCSF has just produced about 5 Nobel laureates in medicine, and to have a collaboration, I think the question should be, it shouldn't be why, it should be why not. So I'm really glad that you made this decision, and really thank you for coming over and to be part of this evening function, and to all the staff of Washington Hospital who took this giant step to make this happen. I think this is a great milestone. 10 years from now, I think probably we'll know where we stand. I think that is the key thing, to maintain the relationship. Because a lot of relationships are made, but the question is how long does it last? So I'm really hoping that this will last for a very long time, and this will be written in stone. Thank you again.
Thank you, Jacob. Mike?
Okay, first of all, I'm sorry I'm late.
You're excused.
Thank you. And thank you, Bernie, for helping me. I'm thrilled with the association, and I'm going to tell you why. You have a world-class organization, and your level of patient care and the all of the resources that you bring to bear on helping people survive, keeping them alive, and helping them is just significant. It's really significant. So at the end of the day, to me, it's a no-brainer association. Our world is like completely filled with so many what ifs and what it would be like, and there are so many uncertainties right now that we all face with the new Healthcare Reform Act and all of that. But beyond that, even if that act never happened, the association with your university and all of the, with your, what I'm talking about is a benefit to the district's residents, and that's what's important to me, because over the course of time, things change in healthcare, and we have great docs in our community right now. We have great specialists in our community right now. But there is all of this political stuff that's going on, which nobody knows what's going to be the ramification for all of our physicians. And I think that it's important that we affiliate with you in a way that gives our physicians access to your facilities and gives our patients access to your facilities. And at the end of the day, I think it's going to benefit both of us to be in concert with you. So, I'm really thrilled about the affiliation with you, whatever shape that takes. Maybe 30 years ago, 20 years ago when I got on the board, we said, well, why would we ever want to have anything to do with anybody in San Francisco? Well, you know what? You can't live 20 years ago. You can't live 30 years ago. This is the new world. And I think we're blessed that Nancy and you have come together and created an opportunity for both our physicians, but more importantly, our residents and our patients to benefit from a association with you. So I think it's just great. I feel like I'm Adam Levine or somebody, or The Voice. What? Yeah, singing to the choir. Yeah.
Great. Thank you, Mike. Bernie?
I am born and raised in this area. I have 13 grandchildren that are citizens, residents of the Washington Township District. So I have a very, very personal interest in their health care. I think about that, I pray about that every day. And being on this board has been a wonderful, wonderful experience for me, where I've been able to associate with this tremendous organization, where we've been able to do wonderful, wonderful things for the community. I've always held UCSF in great awe. In fact, I have to admit that when I go up there for continuing education work, it's just a thrill for me to be on that campus. And the fact that we've been able to work out a collaborative arrangement with a unlimited future, really, with that organization makes me very, very much in favor of this resolution tonight. I think it's an opportunity that is unmatched in this area for other institutions. I think we owe a great deal of thanks to our CEO and to the administration, others in the administration. Thank you, UCSF. This will be a great thing. I am tremendously in favor of it. I'm hoping that when my youngest grandchild, who's about 3, is 50, we'll look back at this as a major decision in Washington Township's history. This will be a turning point for the future. It will be an opportunity that will keep us current with what we're doing right now. So I add my voice to the other board members that this is a good thing. I'm happy that it's happening.
Great. Thank you very much, Dr. Stewart. This time I'd like to invite Dr. Romano to make a few remarks.
Thank you, Dr. Nicholson. On my own behalf, but on behalf of the entire medical staff, I'd like to congratulate the leadership of the Washington Hospital District for bringing together this partnership. Like everybody says, I think it's going to be wonderful, but I'd also like to welcome my colleagues from UCSF to our community. We look forward to working with you. Thank you.
Thank you very much. At this point, I'd like to invite any member of the public to address the board on this matter. Well, seeing none, I'd like to just make a few comments myself. This relationship is really the culmination of a vision that this board has had, I think, long before any of the current board members have sat on this board. It's, I think, critical to the long-term development of Washington Township Healthcare District to be partnering with what Mr. Wallace described, and I think quite rightly so, is a world-class academic medical center. I'm glad to see that we're working to develop a world-class community hospital here, working in collaboration with UCSF. I think the comments that Mr. Larrett made about the changes coming in medicine and the necessity for this kind of collaborative relationship are really quite true. And I think there is going to be strength in numbers, strength in partnerships, developing the networks by which we provide care to our patients. It's no longer the case where a single physician can manage all of one patient's medical issues and medical problems. These networks are going to expand with respect to physicians, specialty services, but also will expand with respect to information, the sharing of information. One of my interests in medicine is that of quality. And as we've struggled with trying to optimize the quality we provide here at Washington Hospital, one of the challenges we've had is really trying to discern what are the best practices, what are the best things, what direction should we go. We look, but it's not always easy to see the answer. And I think having this kind of collaborative relationship, mutually beneficial relationship with UCSF will help us achieve the quality goals and really achieve the triple aim of providing higher quality care, best quality care, along with an absolutely superb patient experience, which the patients deserve. And finally, the third of the triple aim is actually trying to reduce costs. And I think working with an institution like UCSF in a collaborative relationship will allow us to help discern what are the optimal ways we can take care of patients and do that in a cost-effective manner. There have been many comments made around the table here today. One comment was about the cultural fit, and I do indeed believe there is a good cultural fit. There's been a lot of physicians on our medical staff who have either gone to UCSF Medical School or trained in a UCSF residency or fellowship program. I know that's true of my wife. She did her nephrology fellowship as part of a UCSF program. I know this relationship will have many fruits. It's going to be a very fruitful long-term relationship. But I think one of the sweetest fruits that we will get out of this relationship will be the human aspect of it, the people that will work with each other, the students who will come down here and learn what life is like in a community hospital, the residents who will train here. That will benefit UCSF and their trainees. And Washington will mutually benefit because we will have the opportunity to recruit from a top-notch pool of candidates. The quality of care that we deliver in the future will, I think, largely depend upon who is walking the hallways and working in the operating rooms and the clinics and the emergency room of our facility. And I know that having this relationship will considerably enhance those who will provide care to people such as Bernie's grandchild. So I look forward to a long-term fruitful relationship, and I greatly appreciate all the hard work that you, Mr. Larrett, and you, Dr. Hargood, and Nancy, that you've done in making this come to this point where we can actually take an action.
I'd like to include Kimberly Hartz in the congratulations. She's worked very hard on this.
Oh,
and
indeed.
it would be an oversight not to mention that.
No, I know Kimberly is very hard worker, and I know she makes it happen.
Yes, she does.
Yeah. At this point, I
Time
would
for
like
a
to call the question. And we have a motion and a second. And Colleen, I would like to have a roll call vote.
Okay. Dr. Nicholson?
Aye.
Dr. Stewart?
Aye.
Mr. Wallace?
Aye.
Dr. Eapen?
Aye.
Ms. Daniels?
Aye.
Motion passes. We've now affirmed our relationship. At this point, I'd like to have the opportunity to present a few items to Mr. Larrett, Dr. Hogwood. So we've talked a lot about history, and what we have here is the history of Washington. No.
Thank you so much.
You're very welcome. Thank you for taking the time to come down here and join us in this. And at this point, I'll use the gavel.
Okay.
And adjourn the meeting. Okay, we're going to reconvene the meeting and proceed on with our education sessions. And Nancy, if you could introduce our first speakers.
The first speaker is Ed Fayan, who is well known to you. As I mentioned earlier, we're about a couple weeks away from cutting over to our electronic health record. And we've talked about it on and off in the meetings, but I wanted our public to understand what it is we're doing, why we're doing it, and what a monumental effort this is. And so I asked Ed to prepare some brief comments that would create an understanding.
Thanks, Nancy. And I did want to introduce Dave Starr, who's next to me, is the project director for the EPIC project. Dave joined us about a little over a year ago in March of 2012 and worked on revenue cycle, and then moved on to take over the program director position for the project. So I wanted to make sure the board was introduced to Dave Starr, knowing that we're 18 days and 5 hours away from cut over, and Dave will probably be a familiar sight for people. So I just wanted to make sure everybody had met Dave. So thank you. Okay, so WeCare. And WeCare is our new electronic health record that, as it says here, will synchronize healthcare, clinical care, scheduling, registration, and billing. But I just wanted to take a minute and say that's maybe fancy language to say it's the chart. So when you go to your primary care physician's office and he opens the door and comes in with a folder that may have information in it from tests you've taken, from notes from his medical assistant, and then he uses that to take histories from you and write down particular information. That's one chart. And then if you're referred to a specialist, he also will come into a room with another folder that may or may not have information from the primary care physician, additional information from his medical assistant, and then he will also utilize it to get information from you and perhaps order tests and get more tests there. And then finally, if you come to the hospital, it may be a little bit more transparent to you because the nurses and doctors that are taking care of you are going back to the nurses station and noting things in the chart, ordering tests, etc. And historically then we have a variety of places and a variety of offices that have your chart, and your chart is actually multiple charts in multiple locations, most of the time not being coordinated and most of the time not having the information from all the rest of them in one place. And so an electronic health record is actually taking all of those charts, those paper folders, or those folders that contain papers, and putting them in a central data bank in a computer, and that anywhere you go, that chart can be pulled up and accessed by any one of those providers, and as it turns out, more that historically haven't had access to it. So the medical record, or the electronic health record now, is called, for the Washington Hospital, WeCare. If you hear people talk about we're doing EPIC, EPIC is more of a generic term and is the company that makes the electronic record. So it's sort of a generic name at Washington Hospital, and in the Washington Hospital healthcare system, that will be called WeCare. And WeCare will support not only the hospital, but all the physicians in the medical foundation. It'll support the clinics that are associated with Washington Hospital, and it'll be in the offices of other physicians that are not in the foundation or not in the clinics, but they are in the Washington District area providing care and working closely with Washington Hospital, they will also have the electronic record. Ultimately, and we'll get into this in a little while, it will be available to patients to access online, and they'll have a variety of capabilities through that. And I think in a generic sense, the online medical record will obviously make things safer for patients because all the information will be right there. Anybody that needs to access that information to provide care to you will have a complete and total picture, which hasn't been the case historically, or potentially hasn't been the case historically. And then that information is going to be available to a variety of other people that have medical record. We talked about UCSF tonight, and that's probably the perfect example, that they will have, because they are a fellow EPIC provider, there will be a connection, and if you are referred or go to UCSF, they will be able to pick up your history here with your primary care physician, your specialist here, your inpatient stay here, and then anything that's going on with your health or treatment at UCSF. And finally, we're doing this because we're doing it, obviously, I think the overwhelming issue is that it's going to provide better care in the community. It also is something that is required by CMS, the administrator for Medicare and Medi-Cal, particularly Medicare, by 2015, that all hospitals are supposed to be on an electronic health record. So our timeline, if I can go over it briefly, the board approved this project as Resolution 1099 on November 10th, 2010, and the project budget is in excess of $80 million. Immediately after that approval, obviously contracts had to be negotiated, and then we moved on to staffing this project. There are 100 people that are involved in the build of this project, and they came from contractors, internal staff, and some EPIC, very few EPIC people. And so there had to be a staffing build-up and then a certification of people in that, in the EPIC medical record. That certification is necessary because the build that happens is, while there is a generic record that is provided by a provider, by EPIC, it has to be customized to this institution and surrounding clinics. And so that's what the build is that literally hundreds, thousands of different aspects of that record have to be tailored to the Fremont community. The physician office build and testing occurred between October 2011 and November 2012, with the first WTMF or foundation physicians going live in December of 2012, and the last of those areas in the foundation going live in April. Our first physicians that were community physicians that are not in the foundation went live in May of 2013. The hospital build and test actually started at about the same time as the outpatient or the physician clinics, physicians' offices and clinics, and was completed, actually is being wrapped up, and the testing is wrapping up now. And we plan to cut over the evening of June 30th into July 1st. Then later in the summer, plan to offer the online capabilities of the medical record so that patients can get online access to their record. So, as discussed, the EPIC or the WeCare is going to be the most comprehensive most comprehensive and secure record that is out there. The best benefit, the highest integration of any system that is out there. And as discussed, it will allow one place for a patient's information to be placed and one place for multiple people to access it. And the system then, once that goes in, it's going to have a variety of tools and capabilities to put in, to reduce errors and to evaluate care on a larger scale. And the intention will be to improve quality overall for people as we can take a look at aggregate data. In the future, patients will be able to look online and see portions of their medical record, receive test results, schedule appointments with their physicians, and ultimately with at the hospital as well. The secure exchange of medical information will be able to be passed on or shared with UCSF and other institutions, and you can see that locally all the major healthcare providers have Epic and will be capable of being tied together in a larger network. So you can see the John Muir's, the Kaiser Permanentes, the Sutter Health also have this capability. So WeCare will be totally integrated with the larger networks around here. So this has been a significant effort. As I've said, it's been gone on for multiple years. Just to give you an idea, there's millions of patient encounters that have occurred in offices, in clinics, in the hospital, in the township area. And it took us 4 months just to get all those records and encounters into the master database. And then from there, as you might imagine, we had a major duplication or deduplication effort to make sure that patients were individually identified, corroborated, and then their records consolidated under one name and one set of identifiable markers. Nancy Farber had met with multiple people that had implemented this electronic record around the Bay Area, and the message that she heard was basically training is king, and your success is totally tied to the amount of training and education that people have ahead of time. And the better educated they are, the more familiar they are with the system ahead of time, the greater your chances of success are, because this is a tremendous change from the way care has been provided and recorded, and people need to get familiar with this. And I think anybody that has tried to master a new computer program or a new computer software program understands that there's a high frustration level when you're trying to maneuver around the latest version of Windows Office or Windows 8. You know, I mean, it's just difficult. Well, this is you kind of have to multiply that many times over. That's how complicated. This was a very complicated record, and people are going into it for the first time. So you can see we have over 1,800 employees. We have over 500 physicians, and a massive training effort was undertaken. Now, not every employee and not every doctor needs to touch this record, but as you can see, 400 of our physicians have spent over 3,000 hours in training so far, and it's continuing on to through this time. That number will just go up between now and July 1. Same for the 1,600 employees. You can see almost 23,000 hours of training. That will probably top out around 26,000 or 27,000 hours by the time we're done and ready to cut over. So the hospital cutover is going to be a fairly choreographed event, and there will be a period of about 48 hours that it'll take to complete. So actually, a couple of days ahead of time, all the people that are slated for admissions, the appointments for outpatient departments, the appointments for places like labor and delivery, surgery, cath lab, will all be entered into the system, and this will be a couple of days ahead of time. The day before go live, all the patients that are currently in beds in the hospital will be registered into the system, and that will be followed by a manual entry of all the important information about the patients, meaning height, weight, allergies, vital signs, lines, drains, airway data. All will be manually entered into the system, and then that will be followed by pharmacists entering all the medications that people are on currently in the hospital. So there's this massive effort to load the record both the day before cutover and a couple of days before that. The day of cutover, then, immediately after cutover, there will be a manual entry of the non-medication procedures and orders that have to be also implemented. So it will be a significant effort that's going to go on over a 48-hour period to get the record ready for go live and then cut over and then get all the information on there so that care can be provided in a coordinated and organized way. In addition to that effort, then, there's a number of people that are going to be in the hospital for the cutover. And this is going to be people here on a 24-hour basis. So you have to think of these people, these number of bodies here to work and to help are going to be spread over 24 hours, 7 days a week for a period of about 3 to 4 weeks. So to begin with, we have 20 physicians of all different specialties that will be here to act as advisors, super users, helpers to physicians on staff. We have 200 employees and contracted super users, people that are very facile with the programs that will be here to help the hospital staff. There are also going to be about 30 people here from Epic that are going to serve as resources to the staff. They will also be out on the floors and available. And then we have approximately 35 trainers that have been working and training people up till now, and they will continue on and do training on a real-time basis after we're live. And finally, there will be a group of employees and former employees that have come back that will be going around the hospital and working with patients and family members who may have questions about what's going on or what is the electronic health record, and being basically sort of advocates, ombudsman type thing to help people understand what's going on. So as I said, the transition will take about 4 to 6 weeks until we're hopefully, everybody's trained, using it, facile, and things will flow pretty well. So I think that people can probably expect delays and kind of startup of this thing in terms of care and getting all the bugs worked out. We will keep people here deployed until the training is complete and there's a comfort level that people are comfortable and facile with the system. And there will be an investment in training and dedicated hospital staff to keep the system working and optimized after the go live. So with that, any questions?
I have a question. Ed?
Yes.
I have a question. All of our physicians who are a part of the medical foundation, they will be a part of the WeCare program.
Yes.
Did I get that right?
Yes, WeCare.
WeCare.
They're already on WeCare,
WeCare,
yes.
okay. How are we going to interface with the doctors who are the individuals out in the community who are not a part of the medical foundation? I know that those doctors, when they practice here, when they have a patient in-house, will be using the WeCare system, but how is that going to translate over to their offices?
Not all of them want this in their office,
Okay?
and you can't compel them
No, I
to adopt it.
understand
It's
that.
expensive. The government has created safe harbor from stark prosecution for electronic health records, and they, in fact, extended the deadline where it was going to expire, because they don't want hospitals giving things to doctors that doctors don't pay for, but they also recognize the electronic health record is a huge capital outlay and that most physician offices can't afford to do that on their own. They need a break. So they've created an allowance for that. But it is an individual physician's choice. And we do have the ability to extend this to doctors that are interested in doing it. But it's a huge thing, and it's very disruptive. So you can understand why a lot of doctors, especially those that are at the other end of their career, don't want to disrupt their office and do this again. There are other physicians who already have an electronic health record in their office and don't wish to change. So that, there's varying circumstances out there, and we have no ability to compel doctors to do this.
Patricia?
Yeah.
As Nancy was saying, an outside physician who's not affiliated could choose to purchase software, WeCare software, and access it directly. But for those who don't, we can access the hospital's WeCare through the internet portal.
Okay.
So there will be access.
That's what I was looking
Yeah.
for, was how
Exactly.
is that?
But it's not the same as having it
Right.
one
Right.
record, no matter wherever you go.
Right.
Because I recognize it's extremely expensive. It's a great outlay of capital, but I wanted to make sure that there was a transfer of information, and the portal is the key.
Yes.
Okay, thank you.
Sure.
You can't make people do it.
Any other questions for Ed before he goes?
Good luck.
We'll see you in July, Ed.
Every day.
Or every night.
And we
Okay.
have a second session this evening.
Yes.
And Dr. Vandana Sharma is here. She's our medical director of the oncology program and also of our hospital cancer genetics program, which she basically established here for us. She chairs or co-chairs several committees, including the Cancer Committee, the Medication Analysis Committee, and the Breast Health Task Force. Due to her leadership on the Cancer Committee and Breast Health Task Force, the American College of Surgeons Commission on Cancer awarded the Outstanding Achievement Award for accredited cancer programs to Washington Hospital in 2009 and then again in 2012. She's also an active member of the Department of Medicine Committee, the Pharmacy, Nutrition, and Therapeutics Committee. She has herself received the Empowerment Award from the HERS Foundation and the American Society of Clinical Oncology Young Investigator Award. She actively gives back to our community by serving as a board member of Drivers for Survivors and earlier for Pathways Home Health and Hospice. Her group, VMOC, actively participates in the Fremont Relay for Life. She completed her undergraduate and graduate education with an MD and PhD from the University of Chicago and completed her residency and oncology fellowship from Stanford University. She joined Washington Hospital medical staff in 2004. When she's not doing all of that, and I don't imagine there's much time left, she likes to spend her free time with her husband and her 2 sons, and they enjoy theater, the opera, camping, hiking in the California outdoors. I'd like Dr. Sharma to do her presentation on medication safety.
Thank you very much. You can hear me? Okay, good. So I appreciate this opportunity to come to speak to the board about what we've been doing here at Washington Hospital with regard to medication safety. So a brief outline of the talk I'm going to give. It'll be in 4 parts: medication safety today, regulatory compliance mandate, safety initiatives, and a culture of medication safety. So in the 21st century, medicine and the practice of medicine is very complex. It used to be simple, ineffective, and relatively safe. And unfortunately now, or fortunately, it's very complex, more effective, and potentially dangerous. So we have to be very cautious with the medications that we give to our patients, as well as be cognizant of the risk of the providers in terms of their exposure to these medications as well. So there became data that showed from the Institute of Medicine that a hospitalized patient experiences at least 1 medication error per day. And this leads to a high burden on the community. And at least 1/4 of those medication-related injuries are thought to be preventable. So it's obviously a very big problem that we need to address. And in the US, at least 1.5 million preventable adverse drug events occur annually in 2006 for an estimated cost of $3.5 billion. And mortality rates attributed to medication errors range between 1 and 2.45%. So it's really a big problem, and we clearly needed to have an action plan to prevent harm to our patients. There's also mandates that came from various regulatory agencies to put in place medication error reduction plans, or a MERP plan, as we like to call it. And for example, from the California Department of Public Health, a formal plan, the possession of a formal plan, is a condition of licensure. And that plan must have information to eliminate or substantially reduce medication-related errors. So it came from passage of Senate bills and the Health and Safety Code. And each institution is required to have a MERP plan or a medication error reduction plan, which is reviewed annually by the hospital for effectiveness and is approved. And the medication reduction prevention plan surveys are conducted every 3 years by the California Department of Public Health. And our institution had one of these surveys earlier this year, and we passed that quite well without any issues from the California Department of Public Health. So in order to do this here at this institution, we instituted a group called the Medication Analysis Committee, or the MAC Committee. And we have a logo, because I think having a brand and a logo and identifier is really important. So that's our MAC truck up there for our Medication Analysis Committee. And who is this committee, and what is it that we do? So I'm going to tell you a little bit about what happens here. So the issue of medication safety is incredibly complex, because every single person who comes into the hospital is coming here because they need some sort of medication. So this is something that touches every one of our patients. And the process of ordering and delivering the medication to the patient involves many different individual people. So the MAC committee, which is here in the center of this pentagon, has oversight of a lot of information that comes into the committee with regards to medication delivery, medication error, and medication safety. And this committee synthesizes this annual report, or the medication error reduction plan. We review cases that come into the committee that are provided in terms of medication errors that are happening, and generate quality reports and do trending and tracking. And then the information that's analyzed and generated from here is reported to two committees. One is the Pharmacy, Nutrition, and Therapeutic Committee, which is PNT, which is a medical staff committee. So there's monthly reporting up to that committee, and then quarterly to the Hospital Quality Steering Council. So it became very obvious in the early stages of looking at medication errors that this needed to be a committee that would involve all levels of individuals within the hospital, from leadership of the administration, physicians, nurses, pharmacists, respiratory therapy, dietary. So it needed to be a committee that could span the breadth of medication-related issues. We've undertaken various safety initiatives, and these were very important because we all know that that errors happen, that mistakes are a fact of life, and it's the response to the error that counts. So we wanted to generate a committee that wouldn't really be a punitive committee. So the purpose of the committee was not to have a court or a tribunal, but an active working group that would analyze medication errors and medication safety issues, and then try to troubleshoot them and come up with recommendations and proposals to promote medication safety and reduce errors and reduce harm. We get medication errors reported to the committee from various ways. So self-reporting is one way. So individuals who see an error or experience an error can actually report that error in through a computerized system, and then that data gets reported to the Medication Analysis Committee on a monthly basis. We have data that comes from observational studies. So the hospital is participating in a study called CalNOC, where nurses do an observation of other nurses to ensure that they're delivering medications and explaining medication information in proper ways. So it's a self-observation study. And then finally, we also get data from these smart pumps, which I'm going to show you a little bit later. There's a little bit of show and tell for my talk as well. And these are the pumps that are actually used throughout the hospital for the delivery of infusional medications. And these are called smart pumps because they're computerized. And not only do they provide a safe delivery of the IV medication, but they also can give data that goes back to an analysis center. So there's a flow of information back from that pump into a database, which provides real hardcore data for how medications are being delivered. And that's a real key important piece. So the Medication Analysis Committee, we take a huge amount of data and we try to look at it and generate meaningful information from it. So what we don't want to be is we don't want to be drips. We don't want to be data rich and information poor. We don't want to just generate data and give out reports and saying this is what's happening. Our goal is to really get down to the grassroots and figure out how can we solve this problem, how can we prevent this error from happening again, how can we prevent an error from even happening in the first place. So it's part of it is to be very proactive. We tried to transform this gathered data into useful information, use the data to prioritize and improve medication management, safety, and administration. So we don't want to focus a lot of energy on medication delivery of medications that aren't prone to error. So we spend a lot of time focusing on what we call high-risk medications, antibiotics, anticoagulants, certain type of medications that if an error is made, they have a high-risk outcome. We've discovered that it was very important to standardize the medication management process between units. One thing that was happening was that people were going from one floor to another or one unit to another, and when it was clear that policies were not standardized, errors were being made. So for example, we went through and we discovered that different units had different ways of identifying certain high-risk medications, and we realized that a nurse who was, say, used to working in the emergency room and had to go up into the floor may not have been using the same procedure, and that could have led to an error. So we went through all of the inpatient departments, all the outpatient departments, and just uniformly standardized everything so that anybody could go from one nursing unit to another nursing unit and find exactly the same equipment, the same notation, everything the same, so that there would be no chance for error in that way. We then use the data for purposes of training, education, and an evaluation of trends. And that's really important because sometimes there are things that are isolated cases, but sometimes a trend emerges and becomes apparent that that particular system needs modification. So an intensive assessment, in our meeting, it happens very much like this. We sit around a table, but we don't do what they do here, which is that we don't say, to address this mistake, we must use root cause analysis. I'll begin by saying it's not my fault. So at our meeting, we really don't have this approach. We're really not punitive. There's no assessment of who's to blame or what's the fault. We're really trying to understand what's causing the error and what can we do to prevent it and what can we do to make sure that this doesn't happen again. We have a very team-based analysis, which involves assessment and interviews. So if there's an error that happens and we're seeing a trend, there's a certain protocol that we follow to come up with an assessment. And then finally, the reduction strategies we rank based on the highest strategies, which have the highest power, which is forcing function and constraints. It's very easy to say to somebody, if there's an error made, to say, next time, just be more careful. Don't just do it that way, just be more careful, pay more attention to that order, pay more attention to that medication, but that's not enough because being more careful is not sufficient to make sure that error doesn't happen again. So I'll just give an example of what this means, to force functions and constraints. So there was a certain trend that we were seeing in a way a certain medication was being delivered. And pharmacy very quickly realized that one of the reasons that might have been happening was that because the first choice on a pull-down menu mandated that medication be delivered intravenously. And the second choice was subcutaneously, which was actually the more common way this medication was being used. So all that it required was simply switching the order. So the subcutaneous route came first, the intravenous route came second. So when a pharmacist was pulling down their menu, the default was actually the subcutaneous route, which is a safer route. So by forcing function, we could reduce error. So whenever we have an error, we're always looking to how can we force a function on the system that doesn't rely just simply on education or being more careful. And this has been very effective. And part of what we see is a system like this in medicine. So you have a very complex IV system, lots of lines, lots of drips, lots of things happening. And this happens for our patients in the intensive care unit, for example. They have very complex medications, and it's hard to know what's hanging at the top and what's coming out the other end to the patient. So we put into a policy of tracing the line, and this happens with our patients at every nursing shift with every medication, where the nurses look at the medication that's above the pump, trace the line physically with their eye, and then make sure that one is going into the patient. And in addition, there's a labeling system. So for high-risk medications, there's a label that's put up here above the pump, and then a label that's put down here right at the patient's IV access to make sure that the patient is actually getting the right medication, it's flowing at the right rate, and to alert everybody that this is a high-risk medication. So we created an action. There were flyers, educations that were done in services, and then we actually went back and did spot checks to make sure on the floors that this was actually happening, and reevaluated the policy to make certain changes. And there were discussions even as to the color of what this label should be, and making sure that the labels were available in the same place in all the units so that everybody would know where to go and get them. We are challenged by drug shortages in many ways. So before we had all of these drug shortages, we had the luxury of picking different manufacturers to buy our different medications from. So we could be sure that certain high-risk medications didn't look alike because we got them from different manufacturers. Some came in vials with orange tops, some with blue tops, some in pre-filled syringes. With the medications shortage situation, we really have a decrease in the number of vendors that are available to us to purchase medications from. So now we've gone to a situation where certain anesthesia medicines came in 4 different packages. The anesthesiologist could very easily identify, all right, this is one particular drug because this has the blue top, this is an orange top. It was a quick visual reference. Now, these 4 drugs all look like this. So now this has created another layer of potential medication error and another situation where everyone has to be extra careful by reading and making sure that things are in the right space. So every time we come up with a solution, we get a new problem. So this system is a part of creating a culture of safety. So part of what we've done is participate in the CalNOC survey, which is when the nurses are observing other nurses. And there are certain measurements that are done, which is, for example, making sure are the nurses what percentage of doses were given with no errors? What percentage of doses were given with 2 forms of ID checked? And these are areas where we've been very strong, and this has also helped us identify areas where we might need some improvement in the hospital, and we can focus our education and our systems on those mechanisms. We have to do certain compliance measures to comply with Centers for Medicare and Medicaid Services. So CMS had come up with a statement that all medications must be administered within 30 minutes of ordering from the physician. So that was a mandate that had been sent out, and then feedback that they received said that's impossible. It's truly impossible to make sure that every single medication get to a patient within 30 minutes of being ordered. So they came back and said every institution should come up with their own policy. So we have these, so we came up with this policy. I think we have some copies to show to the board, which is a very simple plan. It's just one little piece of laminated paper, and it looks like it's not very complicated, but this one little piece of paper actually represents hours and hours and hours and hours of work from many different committees, many different individuals, to come up with what should be our safe timing of medication administration. And this is something that we now follow. It's very clear, it's very concise, and every nurse and every pharmacist can very clearly know when a particular medication to be given, and this allows us to be compliant with CMS. So this little document, which took us many hours and many people to work on, has permitted our institution to be compliant with CMS and make sure that our medications are administered to our patients in a timely manner. We monitor this. So again, it's back to the whole drip thing. So we're not just being drips. We're not just generating data. We're actually going back and monitoring. And we're going back and seeing how well are we doing with timing of our medication. So how well are we doing with this own policy that we've created? And we've been monitoring 2 particular things, which is delaying more than 3 hours of medication administration and delay of medications given for venous thrombosis. And we've been monitoring the number of cases that we've been getting to make sure that we're being compliant with the policy that we've set up ourselves. So creating a culture of medication safety. This has probably been one of the biggest initiatives, and this is probably one of the areas where, as an institution, we've made a lot of progress, I think, over the last few years, which is to really make a shift in our culture. And part of that has to do with that very first slide, which talks about the complexity of practicing medicine in the 21st century. We now have very high-risk medications, we have very sick patients, and we have medications that can be delivered in multiple ways. So in order to create a culture of medication safety, our team has been very proactive. So not only are we trying to fix errors that have already happened, but we're now thinking about how can we create systems that avoid those errors in the first place. So trying to be proactive. We rely on teamwork, and we've been interacting with unit-based councils, coordinating education and clinical councils, P&T that I talked about, dialysis committee, EPIC committee. Obviously, a lot of the new bills that are going to come with EPIC have positive and some potential negative things in terms of medication safety, so we've been very proactive working with them. Going out and talking to actual medical departments. So one thing that we realized very early was that it's one thing to issue a memo, but it's actually another thing to go in person to the department to say, this is why we need to do this is why this has to change, and that's been very effective. And then obviously working with the Quality Steering Council. We're using technology to enhance safety. So the first thing I want to show everybody is actually one of these smart pumps. So we talk a lot about these smart pumps, but I actually have one. I thought it would be good for people to see what does a smart pump look like. And this is a smart pump. This is one I snagged from the infusion center upstairs. And essentially what it is a very high-tech computer with a pump mechanism that allows the safe delivery of our infusional medication. So the medication would hang up top, a tubing would go through this pump mechanism and then come out and go to the patient. And what's different about this pump than the classic pump is that it communicates to a server, which gathers data, but within this pump is built in a library of all the infusional medications that we have in the hospital. So every single medicine that a patient would get in our hospital has been built into this computer. The dose of the medication, the concentration of the medication, and also what we call guardrails, which is the safe, just like you have guardrails when you go over a very steep curve to just keep you in a safe driving distance, medications that are in the library also have guardrails. So what this makes sure is that we're not underdosing or overdosing our patient, because you cannot override these safety mechanisms that are there. One of the things that came out from the Institute of Safe Medical Practice was one source of error was a concept of a bolus, where a physician says or orders, give this medication as a bolus, give it as a free-flowing drip. And situation can happen when that free-flowing drip is not stopped. The patient can get an overdose of medication. So in the beginning, we didn't have a bolus feature built in, and what we got back from the pumps was that there were a lot of overrides for that bolus. So we were proactive, and we said, let's add in this bolus feature. So we added in the bolus feature, and what that did was it eliminated that problem where individuals were getting too much medication. And the smart pumps are not smart on their own because there are potential override features in them. But once we started using them and got the education out, we actually saw that our data shows that within our institution we have excellent compliance with the guardrails. So we're above the 90% mark. So our nurses are using the guardrail features, making sure that our patients are getting medications administered in a safe way. And smart pumps actually avoid serious harm and actually lead to cost savings. So this is data that's coming from our own smart pumps about how many serious cases were averted because we have these smart pumps. And our data shows that on average, we've averted 176 serious cases or serious potential medication errors because of the smart pump, resulting in about an estimated $1.5 million of cost savings. Continuing on the vein of how we're going to use technology to help reduce medication error. So one of these things is what you just heard about is with EPIC. How will EPIC help us reduce medication errors? And just to do an analysis of one of our top reported drugs, which is vancomycin, which is an antibiotic, there are several types of errors that can happen. There can be an entry or transcription error. So when a doctor hand writes an order, that order has to be transcribed into the pharmacy system, and an error can happen there. There can be an error in actually dispensing the medication, administering the medication, or monitoring. And the EPIC, the computerized physician order entry, will help really eliminate these entry and transcription errors because the order is now going to be entered directly by the physician and go directly into the pharmacy system. So there won't be another middle person in the middle trying to transcribe that error. It's not going to help so much with dispensing, but the dispensing errors overall are relatively low for this particular medication. It will help with administration as well as monitoring. So this is a very busy slide, but basically the idea is to say we're investing in all of these technology measures on this end so that over here, when the patient is actually getting the medication from the nurse, every single step is made safer because of the technology that's been invested into the patient. And at the end point, when there's a physician ordering a medication, a nurse administering the medication, there will be barcode scanning so that the patient will have, along with their name on their wristband, a barcode. The nurse will scan the barcode, will scan the medication to make sure that the right patient is getting the right medication. And all of that information, because of the barcoding system, will be transferred from the technology that's there downstream from that. We have a couple of things that we've invested in to make this happen. So obviously the barcodes, and then we've got these glow-in-the-dark keyboards so that a nurse can actually chart and see the electronic medical record right in the room. And even at night, when the patient may be asleep, the keyboard will light up, the monitor will light up, the nurse can make sure they have the right patient and can actually proceed with safety. We've invested in these pill crushers. So one of the challenges that we were finding was that there were patients who needed their pills crushed for them. The pill crusher was located centrally in the nursing station. So the nurses were crushing the medication at the, in the medication preparation area and then carrying the medication to the patient room. There was room for error in that situation. So now we have these portable pill crushers, which will be at the bedside for certain patients, so that the medication can be crushed right at the bedside. The medication can be scanned, can be crushed, and can be delivered to the patient right there at the bedside. So we had some of these if you wanted to show these around to see what these are. We still have low-tech solutions to what we're doing. Low-tech is still very good. And we've done in-services, interactive in-services. Jen, our medication safety officer, has gone to the different councils and done in-services. Some of them include even quiz shows to get the word out. We have lesson learned flyers, so just, again, low-tech technology, the old way of getting the information out to our staff. And then back to high-tech. So we have an internet icon. So on the Washington portal, there's a page on which individuals can access information on medication safety. What are the FDA black box warnings? Which medication should not be crushed? What about hazardous material? I think it's important to point out that Washington Hospital is not only concerned about the safe delivery of medications to the patients, but also the safety of our staff. So some of the medications that we're giving our patients are hazardous to the person who's administering the medication. So we've created a flyer so that the staff can look and see, is this a hazardous material that I should be cautious about? Medication safety at Washington Hospital is not just a priority, it's our way of life. We're working hard to create a culture of safety. We accept that humans make mistakes. We accept that errors will happen, but we don't let that stop us. We practice accountability through behavior choices. We use the lessons that we've learned from the past to make changes to our future. And we recognize the need for technology and teamwork. And we practice safe medication administration on a daily basis. And I just wanted in my last slide to acknowledge all of the team members. And not so much to point out the specific individuals, but to say that this has really, really taken a village. And the village is not just people who are on this slide, but everybody in the institution. That includes the doctors, administration, pharmacy, nurses, RTs, dietitians, and everybody else who I haven't included. I'd be happy to take any questions. Thank you.
Thank you so much, Dr. Sharma. I appreciate the very hard work you've done. Do we have questions from the board?
No.
I have one question. I have always held that the safest patient is one who is actively participating in their care, either the patient and or their family, and not just a passive recipient. So what can you tell the patients to do to enhance their medication safety? What kind of recommendations could you give to patients and family members about medication safety for themselves?
So I think that's an excellent question. And part of what we do here, and part of what I think is important for patients to recognize, is that patients should be aware of the medications they're taking. Probably the safest thing that they can do for themselves is carry a complete and updated list of the medications that they're on. And that's very easy to do. It can be very low-tech with a pen and paper in your wallet with a name of the medication and the dose, and keep it updated. So many patients come with such lists, but they haven't updated them for the last 6 months. Have that information readily available. Know what you're taking and why you're taking it. And then for patients, when they're in the hospital, to ask the nurse, why am I getting this medication? And what are the potential side effects of it? And to keep that forefront. And for family members to do the same.
Great. Thank you so much, Dr. Sharma. Appreciate it. We'll now move on to consideration of the minutes of May 8, 20, 22, and 28. Do we have a motion?
I move for approval of those minutes.
And do we have a second?
Second.
Second from Director Danielson. All in favor?
Aye.
Aye.
Any opposed? Motion passes. We'll now move on to the communications section of our agenda. Colleen, do we have any cards from any public speakers wishing to address the board? There being none, then we'll move on to Dr. Romano, written communication.
Thank you, Dr. Nicholson. For the board's hopefully approval, the proposed credentials action items for the month of May. For appointments, we have 2, Dr. Rajesh Shingal, urologist, to the provisional active category, and David Lieberman, otolaryngologist, also to provisional active. The reappointments, which are for a 2-year period, are Igor Bedorov, RNFA, which is RN First Assist, Jeffrey Carlson, cardiologist, active, Aruna Chakravorty, endocrinologist, active, Gurleen Dial, physician assistant in Allied Health, Linda Santos, pediatric hospitalist, active, Craig Johnson, OBGYN, active, Gopala Kalaru, cardiology, active, Christina Lee, internal medicine, active, Gerald Mint, internal medicine courtesy, Christine Nguyen, pediatric gastroenterology consulting, Deepti Saxena, family medicine, active, Manish Singhai, internal medicine, active, Dennis Townsend, family medicine, ambulatory, and Sunil Upender, radiology, active. There are 2 reappointments which are undergoing further review. First is Dr. Jenny Multani from neurosurgery, who is returning from leave of absence, and we are granting a 6-month reappointment with privileges indicated. And also Dr. Zulfikar Ali, cardiology. We're recommending granting 6-month reappointment with privileges as indicated. One physician, Dr. Manuel Seppi, failed to submit reappointment, so he is deemed to have resigned. Dr. David Bell is transferring from active to ambulatory in his specialty of orthopedics. 4 physicians have completed their proctorship. Dr. Yagya Kapila in gastroenterology, moving from provisional to active. Dr. Lee No in pediatrics, moving from provisional to ambulatory. Christine Nguyen, pediatric gastroenterology, moving from provisional to consulting. And Ario Barzin in surgery, moving from provisional to active. There is 1 physician. We are asking for extension of both the proctorship and provisional category. That's Graham Rodwell, a nephrologist. And finally, there are 4 resignations: Zubin Damania, Jimmy Hugh, Timothy Scott, and Dwight Chen.
Thank you very much, Dr. Romano. Do we have a motion for approval of the credentialing action items?
So moved, Mr. President.
We have a second?
Second.
Second from Director Danielson. All in favor? Aye. Any opposed? Motion passes. Jeannie, Service League report.
Thank you. Last month, I was able to tell you that we had selected our 4 winners for our scholarships, but I couldn't tell you who they were because they hadn't yet been informed. But I did want to introduce you to them tonight, just on paper. Exciting young people. The first one winning the Catherine Fusco scholarship of $1,000 It's renewable for 3 additional years, was awarded to David Chung. There's photos behind you. David is the second from the left. And he will be attending St. Louis University and has been accepted into their very prestigious Medical Scholars Program. And he is aspiring to be a physician studying hematology and oncology. The next one on the far left is Neil. He won the Josephine Walton Scholarship of $1,000 a year. That's renewable for a total of 4 years. And he's going to be attending St. Bonaventure University in New York, which is a dual admission program. So upon graduating from St. Bonaventure, he'll immediately enter medical school at George Washington University in D.C. He would like to be a surgeon, and St. Bonaventure only accepts just a handful of students into this dual admission program. So I'm just so proud that a Fremont student is a part of that honor. In the middle there is Gail Tomita. She's our first VP and the scholarship chairperson. She's not going to college. She's already done that.
You fooled me on that.
Yeah, I know. Next, standing to her left, our right, is Syed, and he is going to be going to San Francisco. San Jose State. I'm sorry. And he's not yet sure. He definitely wants something in the healthcare field and thinking about medicine. He's a self-admitted late bloomer. He didn't quite know what he wanted to do, but after attending junior college and meeting some dynamic professors, he definitely wants to try and pursue medicine. So we're going to give him a shot. He and the gal next to him, Jenna, are sharing an $1,800 scholarship, so they're each getting $900 a one-time scholarship. And Jenna, standing next to him, is our only girl, our only nursing student. She's going to be attending San Francisco State University. And bless her heart, she loves geriatrics. So I would like to multiply her and bring her back, because we're going to need her heart. So thank you.
Thank you, Jeannie. What wonderful talent we have.
Yeah, very, very hopeful for the future here.
Yes, good. Dr. Romano, medical staff report.
The first part about my medical staff report is that this is my last meeting as Chief of Staff, and I just want to say it's been an honor and a pleasure representing the medical staff to the board.
It's been a pleasure to work with you, John.
Thank you. So first page is the overall numbers, that we have 516 total members of both the medical staff and allied health. 389 of those are active and provisional active members. Just kind of interesting to note, family medicine has almost as many ambulatory members now as active, 29 versus 20. And medicine remains the largest, 196, with surgery second with 121 members. Also kind of interesting is 81% of the medicine department is active, whereas only 55% of the surgeons are active. Just kind of interesting. The applications which you acted on tonight, of course, Rajesh Shingal and David Lieberman. And then coming down the pike, we have 14 pre-applications and 7 applications in process, and they represent a wide variety of specialties.
Great. Thank you very much, Dr. Romano. I appreciated all the hard work you've put in the last 4 years, and you got another couple of years.
Couple years to go.
As,
I'll
Chief
help
of Staff Emeritus.
in whichever way I can.
Okay, thank you. Let's move on to our calendar.
Okay, Joseph.
Past health promotions and outreach events. On May 11th, Washington Hospital staffed a booth at the Healthy Kids Expo at the Newark Silliman Activity Center. Coloring books and information on health resources were provided. Washington Hospital was a sponsor of this event. 450 people visited the Washington Hospital booth. During the week of May 12th, Washington Hospital celebrated National Hospital Week, inviting employees and volunteers to take some time out and have an ice cream sundae break. In addition, staff and volunteers were treated to an appreciation lunch. On May 13th, Lucy Hernandez, Community Outreach Coordinator provided osteoporosis screenings for the Dominican Sisters of Mission San Jose. This was in conjunction with a health project being conducted by the Cal State East Bay nursing students. 22 osteoporosis screenings were provided. On May 14th, Dr. Rakesh Safaya, vascular surgeon, presented on deep venous thrombosis. 50 people attended. On May 17th, as part of the Washington Women's Center Lunch and Learn series, Alicia Davis, certified yoga instructor, presented on fall prevention and balance. 37 people attended. On May 18th, Washington Township Medical Foundation participated in the City of Fremont Recreation Department's Kids and Kites Festival. Washington Township Medical Foundation was a sponsor for this event. Over 200 people visited the Washington Hospital booth. On May 21st and 22nd, Washington Hospital and Washington Township Medical Foundation participated in a health fair at Tesla Motors Auto Manufacturing Plant. Staff provided blood pressure, blood glucose and cholesterol, body fat and body mass index screenings, and information on healthy nutrition. Over 500 people visited the booths and participated in the screenings. On June 1st, Washington Hospital sponsored the 7th Annual Women's Health Conference. Dr. Barbara Kostick, Family Practice, Dr. William Degoni, General Surgeon, and Dr. Sunil Dewan, Dermatologist, presented at the event. In addition, attendees participated in seminars on yoga and self-care and visited health information booths staffed by Washington Township Medical Foundation, Washington Hospital Food and Nutritional Services, and Sprouts Grocery Store. 92 people attended. On June 4th, as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, presented Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. 36 people attended. On June 6th, as part of the Diabetes Matters program, Sandra Murdesdorf, RN, presented On the Road with Diabetes, Traveling with Diabetes. 17 people attended. On June 7th, Washington Hospital and Washington Township Medical Foundation participated in the Four Seasons of Health Expo put on by the Tri-City Elder Coalition. Washington Hospital provided osteoporosis screenings and health insurance information. Washington Township Medical Foundation provided blood pressure screenings. Over 200 people visited the booths and 52 osteoporosis screenings were provided. Also on June 7th, Washington Hospital and Washington Township Medical Foundation provided information on health-related programs and services at the Fremont Bank Employee Health Fair. 200 people visited the booths. On June 8th, the Washington Hospital medical staff hosted a dinner dance. The event honored Dr. John Romano, plastic surgeon, for his leadership as Chief of Staff for the past 2 years and welcomed incoming Chief of Staff Dr. Peter Lunny, nephrologist. The event also recognized Dr. Moses Tagioff, neurosurgeon, with the 2013 Ramos Cerruti, MD, Physician of the Year Award. 172 people attended the event. Upcoming health promotions and community outreach events. On June 19th, from 10 a.m. to 1 p.m., Washington Hospital will participate in the Acacia Creek Assisted Living Facility Brain Wellness Fair. Staff from Food and Nutritional Services will provide information on nutrition for a healthy brain. On July 2nd, from 6 to 8 p.m., as part of the Stroke Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, will present Introduction Stroke and Risk Factors for Stroke. The Washington Hospital Healthcare Foundation Report. On May 23rd, Kathy Hamilton, wife of Rotary District 5170 Governor Joe Hamilton, Lieutenant Governor Jaboy Koshi and several Rotary Club presidents presented Washington Hospital Healthcare System with a donation of receiving blankets for newborns in the birthing center. The blankets were donated by Area 3 Rotary Clubs. On behalf of Washington Hospital, Carmen Williams, nurse manager of the birthing center, received the donation and thanked all the Rotarians for their generosity. Our families, Carmen noted, will be thrilled to receive these gifts. The Foundation Golf Committee is working hard to ensure a great day of play for golfers at the Washington Hospital Healthcare Foundation Golf Tournament, being held at the Black Hawk Country Club in Danville on June 24, 2013. The tournament, named in memory of longtime Fremont businessman Jean Angelo Pisano, raises money to support hospice care and surgical services. For sponsorship opportunities or to reserve your foursome at the tournament, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members represented the hospital at the 10th Annual Charity Ball hosted by Indo-Americans for Better Community on May 11th. The Ohlone College Foundation Scholarship Presentation Reception on May 29th. The 12th Annual Celebration Reception hosted by One Child on May 31st. The Citizen of the Year Gala hosted by Ohlone College Foundation on June 1st, and the Rotary District 5170 Annual Chili Cook-Off on June 9th. Washington Hospital Employee Association, WEA. On Memorial Day, 150 WEA members and their families attended the San Francisco Giants versus the Oakland A's baseball game at the Oakland Coliseum. The winner of the $2,000 Don Peckinpah Memorial Scholarship for 2013 is David Chung. He is currently attending Amador Valley High School in Pleasanton. His anticipated major is biology pre-med. David has been accepted to Union College, St. Louis University, and the University of California, San Diego. David's father is Edwin Chung from the pharmacy department. This scholarship is presented to a dependent of a Washington Hospital Healthcare System employee who is attending or planning to attend an accredited community college, university, or vocational school. The scholarship is named after Don Peckinpah, who served on the Washington Township Healthcare District Board for 26 years. Washington on Wheels, WOW, Mobile Health Clinic. During the month of May, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center and Fremont Family Resource Center, the Silliman Activity Center in Newark, and the New Haven Adult School and the Ruggieri Center in Union City. The WOW Clinic also provided health care services to students and families at Briar Elementary School, Grimmer Elementary School, Robertson and Irvington High School, all located in Fremont. WOW provided 11 wellness exams for members of the Operating Engineers Union through Health Dynamics. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was May's most viewed web page with 15,427 views. Other active sections include InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78, InHealth, aired new programming including a Diabetes Matters program, diabetes meal planning, a health and wellness seminar on deep vein thrombosis, and the May Board of Directors meeting. Additional updates and awards. Dr. Jacob Epen, pediatrician, was named to be a member of the board of the Public Health Alumni Association at the University of California, Berkeley. He is a Washington Township Healthcare District Board member. Washington Hospital, a designated cardiac receiving center for Alameda County, is a recipient of Alameda County Emergency Medical Services Professional Partner Award. The award recognizes the emergency department's teamwork in administering life-saving interventions to a cardiac arrest victim. For more information on any of these programs mentioned, visit WHHS.com or call 1-800-963-7070.
Congratulations, Jacob. You didn't tell us about that.
I saw it in the paper.
Thanks.
We have another honor to announce.
Yes.
I became aware of after this video had already been prepared. The American College of Clinical Engineering has awarded to Paul Kelly a Professional Achievement in Management Award, Managerial Excellence, for his clinical contributions to the clinical engineering profession. This was presented to him on June 2nd this year in Long Beach, California at their annual meeting. So we want to congratulate Paul Kelly. I also have the pleasure of announcing this month's Employee of the Month. It's Jessie Brace. She began working in our medical imaging department as a per diem in October of 2003 while he was in college. He now works as a full-time informatics specialist for medical imaging. It's a highly specialized function. In his role, he's responsible for all of the medical imaging computerized systems. It's a pretty important job, such as picture archiving, communication system known as PACS, and the radiology information system, among several others. He serves as an excellent resource for the physicians. He can assist physicians in both the hospital venue and in their private offices as they have issues viewing imaging documents. If a physician's having difficulty viewing these images, he solves the problem, and I understand, does it with a smile. In addition, he works with patients to provide them with their radiology records, and he makes sure they receive what they need quickly and efficiently. He's professional, knowledgeable, and really lives up to the patient-first ethic. He shows great responsibility for doing what needs to be done and makes sure it is done correctly. He's married to Farina, who also works in the medical imaging department as an ultrasound technologist. Another happy Washington hospital couple, of which there's so many. We're very fortunate to have both of them as our employees, and we want to congratulate Jessie.
Wonderful. Thank you very much, Nancy. We'll now move on to our quality report. Stephanie, we're going to be presenting the Quality and Patient Safety Dashboard for the quarter ending March 2013.
Thank you, Dr. Nicholson. Just as a reminder, in terms of what we measure, a goal is measurable accomplishment achieved over time. Benchmark, which we talked about a lot, you'll hear it a lot, is best practice that you strive to meet or exceed. Internal benchmark is when you best practice against yourself and benchmark against yourself. And comparative rate is a rolling benchmark that retains data from prior years and add new data as available. So let's look at our patient safety indicators. The first one is the handoff communication. And as a reminder, the handoff communication is the handover of the patient from one caregiver to the next or from one level of care to another. And we met the goal for the past 2 years of 99.5%. The goal is 90%. For the procedure timeout, and this is the patient safety checklist, making sure that it's the right patient, the right site, the right procedure at the right time. The goal is 100%. We were 98%, but the procedure timeout was done. Right now, we're looking at completeness of documentation. So the timeout was done, but every box needs to be checked. The procedure timeout form must be signed. So this is what the focus is right now, and we're at 98.0%, and there's a lot of work being done to make sure that it is complete. Moving on to falls with moderate injury, we monitor all falls, but these are the falls with moderate injury. For the quarter ending March, we had 3 falls with moderate injuries. We continue to have hourly rounding and paying attention and making sure the patients are assessed for pain, body positioning, and placement. A lot of the patients are elderly. They want to maintain their independence, and sometimes they don't realize that they're in a strange environment. All falls are analyzed. There's a post-fall huddle that's done. We look to see whether or not there is some kind of medication component to it and what can be done. So again, every patient is assessed for falls, and we do follow the national standards in terms of fall prevention. With severe sepsis mortality, this has been integrated in terms of how we provide care in our practice. Every patient gets assessed for sepsis. We continue to see a decrease in the mortality. And again, with sepsis, the sooner it gets diagnosed, sooner intervention, it decreases mortality. Looking at pressure ulcers, this again, we are benchmarked against CalNAC, and with CalNAC, this is just a prevalence study. It's one snapshot, one point in time, one day in a quarter, where all the patients are looked at and assessed for pressure ulcers, and we had 3 in the quarter. We continue to be diligent in terms of making sure the patients return, assessing their nutrition. So there's a lot of work that's being done in terms of pressure ulcers. In terms of hospital-acquired MRSA infection, we had 0 for this quarter. Again, we are being vigilant in terms of continuing to educate the employees and the staff and physician about hand hygiene. There have been aggressive cleaning in terms of how we clean the rooms. So there's a lot of work that's being done as it relates to prevention of hospital-acquired infections. Hospital-acquired C. difficile, again, if that patient comes in with diarrhea and a culture is not done within 48 hours, then it becomes hospital-acquired. So they may have come in with a C. difficile, but if it's not cultured timely, then it's considered by the CDC as hospital-acquired. There is a lot of work that's being done around hospital-acquired infection. We have an antimicrobial stewardship committee that is chaired by Dr. Martin. Infection control is involved, housekeeping, pharmacy plays a very key role, and as well as all the infectious disease physicians in-house. And over time, we have continued to see some decline in terms of our C. difficile rate. So we continue to focus on that, and now it's becoming, it's reportable to the CDC, so hopefully we'll get better data as the time goes on. Urinary tract infection, this is also considered one of the nurse-sensitive indicators, and we continue to work on the prevention of hospital-acquired urinary tract infection. We're beginning to look at ways in terms of creating a bundle that looks from the time the Foley catheter is inserted, how it's inserted, the care of the catheter. So there's a lot of work that's being done in a multidisciplinary group. Central lines, bloodstream infection. This was one at one point in time in critical care. We had some concerns in terms of the number of central line infections that we were seeing. A group was put together, including all of critical care nurses, physicians, and we have begun to see some results. It takes a lot of vigilance, so we continually have to remind about the hand hygiene, some of the things that we've done, making sure that you scrub the hub for 15 seconds before injecting the IV. So we continue to see some progress with this. And for this quarter, I'm happy to announce that there were no central line infections. Moving on to the core measures. This is we're looking at for quarter ending March, but you're also going to see what's currently on the Hospital Compare website, and the data was updated as of April of this year. So for heart attacks, we were 100% for quarter ending March. And again, these are the three indicators that are most indicative of saving lives, making sure that that patient gets to the cath lab within 90 minutes. We were at 100%. But when you look at our data compared to state and national average, we are better than both. For heart failure, again, for quarter ending March, we were 100%. When we look at our comparative benchmark, we again are better than the state in both the state and national benchmarks. Pneumonia for quarter ending March, blood culture in the ED prior to first antibiotic, we were 92.9%. This is not where we want to be. It's a system issue. We have an action plan in place in terms of making sure that the blood culture is drawn before the first dose of antibiotic is given. So we are hoping over the next few months we're going to see better results. And that is reflective of both the state and the national average in terms of there is some room for improvement there. Moving on to SCIP and highlight for quarter ending March, we were 100% in terms of the antibiotic timing of antibiotic, the appropriate selection of the antibiotic, and making sure the antibiotics are DC'd within 24 hours. So we are 100% in those indicators. Looking at how we compare with the state and national average, and we were better than or equal to in both of those instances. For the outpatient surgery, these are your pacemakers, your gastrostomy tubes that be putting in an outpatient setting. For the quarter ending, there was one concern regarding the appropriate antibiotic timing. Education has been done, but when you look at how we compare with both the state and national average, we were better than both. And this is another measure that you're going to be seeing frequently, and this is the core measure for the emergency department and looking at timeliness. And this is where you look at the time of arrival for admissions and how we compare to the state and national average. And in some instances, we were better than, in others, we were below. And a lot of it has to do with the logistic of our emergency department and how, but as Nancy have mentioned, we should be getting a new emergency department in the next couple of years. So there's good news ahead. But in terms of how long it takes for the patient to be seen by a physician, we were better than both the state and the national average. And I think that concludes my report. Any questions?
Any questions? Stephanie, I have a question. On the procedure timeout, that's a documentation issue, correct?
Correct.
Which requires accurate documentation of all that occurred during the procedure timeout. What is going to happen with EPIC with respect to documentation of the procedure timeouts? Is that going to help us make sure that the documentation is completed?
Correct. It has been built into EPIC.
Good. That's wonderful. It's nice to be able to show what we've actually done.
Yes.
Yeah.
Sometimes the manual record keeping doesn't keep up
Right.
with the real order of business.
Thank you. Thank you, Stephanie. Chris Henry, Finance.
Okay, good evening. Tonight we will be reviewing the operational and financial performance for Washington Hospital for April 2013. And we'll move right into our operating indicators. Our average daily census for the month came in at 160.1. We had expected 190.4. We had 943 admissions in the month. We had budgeted for 1,053. And our patient days came in at 4,802. We'd expected 5,712. Our outpatient observation equivalent days for the month were 51 above the budget at 302. and our average length of stay was 0.56 below budget at 4.86, and that driving a lot of our patient days. Looking at utilization, case mix index for the month came in pretty close to the 12-month average at 1.501. We had 146 deliveries in April. We expected 151. Our surgical cases were 58 above budget at 401. That includes our joint replacement cases that were 50 above budget at 138. We saw 13 neurosurgical cases in April. That's 2 below budget. And our cardiac surgical cases were 4 above budget at 14. PTCA procedures for April came in 10 below budget at 39. Our outpatient visits, we saw 8,646 outpatient visits. We'd expected 8,884. And our emergency room visits came in pretty close to budget at 4,251, about 87 below budget. Looking at productivity, April saw a total of 1,351.5 productive FTEs. We had 166.1 non-productive FTEs in the month, giving us total FTEs 46 above the budget at 1,517.6. Our FTEs per AOB came in at 7.07. We had budgeted for 5.97, and you're really seeing an earlier ramp up in Epic. Moving into the financials, total patient revenue for the month came in $1.757 million below budget at $174,847,000. Our contractual write-offs for the month ended up at 76.75%, giving us net operating revenue almost $1.9 million below the budget at $40,957,000. Operating expenses for the month came in $424,000 below the budget at $41,294,000, giving us our net operating income for the month actually a loss of $337,000. We'd expected a positive bottom line of $1,120,000. Non-operating income for the month came in $846,000 above the budget at $2,125,000, giving us total operating revenue of $1,788,000, about $611,000 below the budget. Take a quick look at our Financial Accounting Standards Board presentation of the financials. This is the way the financial markets look at us. We had just looked at the Governmental Accounting Standards presentation format. I'm sorry I didn't explain that at the beginning. That's the way we format our financials for the audit. From a FASB perspective, our operating bottom line stays the same with a $337,000 loss. We pull out our unrealized gain on investments and our property tax revenue that's used to service our general obligation bonds to give us non-operating income from a FASB perspective of $773,000 and a total bottom line from a FASB perspective of $436,000. So are there any questions on April?
Thank you. Let's move on to hospital operations.
This is the preliminary report for May. We had 973 patient admissions, resulting in 5,036 days of care. We had an average daily census of 162. It was higher compared to April's average daily census, which was 160. The high and low census ranged from 178 down to 139. The budget for May anticipated 1,085 admissions and 5,954 days of care and an average daily census of 192. We're going to be approximately 918 inpatient days of care below the budget for the month. In May, a year ago, the average daily census was 156, with 4,836 patient days of care. Our outpatient observation equivalent days were 332, and we had budgeted 261. And although these days are considered to be an outpatient encounter by Medicare rules, the patients are occupying inpatient beds, and they're utilizing all the same resources as an inpatient, and they don't get counted in the average daily census. The average length of stay in terms of adults and children in May was lower than budgeted, came in at 5.18. The budget anticipated an average length of stay of 5.49. Our preliminary information on patient mix indicates that inpatient revenue for the month of May amounted to approximately $132,876,000 compared to the budget estimate of $142,180,000. Of this amount, 51.2% is Medicare and 6.9% is Medi-Cal, for a total of 58.1% in government program revenue. In terms of births, we saw 164 deliveries in May compared to a budget of 166, so we're just about spot on. May's deliveries resulted in 349 baby days of care, and our newborns totaled 169 for the month, so we had some twins in there. By comparison, there were 174 deliveries in the hospital last year for the same month. In surgery, we saw 376 surgical cases at the hospital, which is over the budget of 357. And this includes cardiac surgical cases that were 6 above budget at 14. The inpatient surgical activity was above budget by 20 cases. Outpatient surgeries were below budget by 1. 652 cases were seen in the outpatient surgery center, which is substantially over their budget of 567, so they're doing quite well. For the month of May, there were 420 cases seen in the cath lab, including 47 PTCAs. The total cath lab cases were higher than budget by 21 in number, or a 5.3% positive variance. PTCAs were lower than budget by 2, which is a 4.1% negative variance. Inpatient cath lab procedures were 12 more than anticipated in the budget. Outpatient procedures were 9 more than expected. So the cath lab was a very busy place in May. In terms of non-emergency outpatient visits for the month of May, we recorded 8,366, or 11.7% lower than what we had planned, and lower than a year ago in May. The emergency room recorded a total of 4,566 patients, a daily average of 147, and they came in just 2 below the budget, so that was another instance of nearly spot on meeting the budget. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinic saw approximately 3,304 patients during May, and this was 483 less than we had budgeted. The total system emergency room and clinic visits for May are going to come in at about 7,870, compared to a budget of 8,355. And the personnel picture is an important one for the board to take note of this month. Our full-time equivalents for the month of May totaled 1,543.8. Of those, 91.1 were agency. And these are the traveling nurses being brought in to free up our nurses to go to EPIC training. And it is an expense of the project. So we're 112.1 higher than our budget. Our FTEs for adjusted occupied bed, ouch, come in at 7.15. I don't think I've ever reported a number like that here. So it's a huge impact getting ready for this. In summary, we had 112 fewer admissions and 918 fewer inpatient days than we had anticipated in the budget. Our surgical cases are above budget by 5.3%. Cath lab procedures are above budget by 5.3% as well. Our outpatient visits are 11.7% below budget, while the ER visits were just 2 lower than anticipated. Clinic visits for the month are below budget by 12.8%. Total paid FTEs are above budget by 112.1, or 7.8% variance. Inpatient charges for the month were lower than budget by approximately $9,304,000, or a 6.5% variance. Outpatient charges are higher than the budget by 11.7%, or $4,598,000. Total hospital charges for May came in below the budget by approximately $4,706,000. reflected a negative variance of 2.6%. On May 31st, there were 163 days cash on hand. The total days revenue and accounts receivable at May 31st was 57.17. The days revenue and accounts receivable, excluding Medi-Cal, were 54.03. During the month of May, $2,161,735 of charges were approved or are pending for charity assistance.
Thank you, Nancy. We all look forward to the completion of our EPIC implementation and all the challenges that has put us through.
Yeah, what I keep telling my staff is that, UC has done it, Stanford's done it, Kaiser has done it, Palo Alto Clinic has done it.
We'll
There's
get
no
through it.
reason why we can't do it too.
Mhm.
It is an arduous process. I don't think you should underestimate the stress level of our caregivers when this system is turned on. It will take time to get used to it. We have to allow that time. We'll have plenty of helpers on the floors. They'll be wearing armbands that identify them as what we now lovingly refer to as super users that will be at the elbow of the physicians and the staff who need help. And we'll make it. It's just a tough adjustment. And it does rearrange how people work. And it will be, upsetting for some people, and other people will take to it more quickly. We'll see how it goes.
It's a big investment. We can see that a lot of the additional personnel that have been brought on in the last few months have gone into the training. And as was said earlier in the meeting tonight, training is an essential part of having a successful implementation of this
Every
program.
administrator I talk to about EPIC tells me that the difference was in training. And those who had very brief training periods did not fare as well, and the adjustment took months longer, months. So I know we've required our doctors to go to training. The medical staff has really been terrific. They've told the doctors, you have to do it, or come July 1, you won't have medical staff privileges.
Yep, they're showing up,
And that
right,
was,
Joan? Yeah.
it was a pretty strong stance that you took, and it's deeply appreciated. And we've got our stragglers in class. There were stragglers.
Yeah.
But with the help of the chief of staff and Jan Hensdorf as our chief medical information officer, we got them through. A little bit more control over the hospital staff and sending them off to training. But I don't think anybody should underestimate how difficult this is and how hard everybody's working. And we have multiple kinds of efforts that are going on now with completing the build. And we have a raft of people that are here for that purpose that will leave when that part's over. We have a whole training staff here to do the training. And then we have the fly-in nurses, the agency nurses here to free up our nursing staff to go to class. So there have been more people in this hospital in the last month than you could possibly imagine.
Well, we'll see how it is next month when we're starting to tread into the progress.
Well, we'll be very early in.
Yes.
And so I just want people to take the long view. We'll
Yeah.
get there.
No, I think we do have to take the long view. It's going to be one that will help us take better care of our patients well into the future.
I think that, there are a lot of people that have put their very best effort forth to make sure that this is successful. And when the time is appropriate, I'd like to share that list with the board of directors. They're deserving of your attention. They truly are.
Thank you, Nancy. At this point, we'll move on to the remainder of our action items, and we've got item B, and Mr. Wallace is going to...
Mr. President, the Bay Area Rapid Transit District, BART, owns property that adjoins Washington Township Healthcare District, which is the real property on which Washington Hospital is located. In the 2012 general election, the voters of the district passed Measure Z, a bond measure that will provide financing for the construction of, among other things, a parking garage which will run along the district BART property line. The district and BART have determined that cooperation regarding development of their respective properties will be mutually beneficial. BART has agreed to transfer a portion of its real property to the district and will provide an emergency vehicle access easement to the district, which will allow the district to construct a more efficiently designed parking garage. The district will lease space to BART in an office building to be constructed and will cooperate with BART efforts to construct a parking garage at a future date should BART decide to do so. I move that the board adopt resolution number 1132, authorizing the Chief Executive Officer to execute the agreement between the district and BART, and the Chief Executive Officer is authorized and directed to deliver the executed agreement to BART and to take any and all future actions necessary, which in the determination of the Chief Executive Officer incorporate the substantive intent of this resolution and to perform any and all other actions contemplated by this resolution and the agreement.
Second.
Okay, thank you. We have a motion and a second. Nancy, do you or Ed want to describe
The
what's going on
details
here?
are that we wanted to build the most efficient parking structure we could, getting the most spaces we can. We had constraints because of the property lines between us and BART, and they've agreed to transfer to our title about 6,000 square feet of space, and that allows us to build a rectangular structure instead of a trapezoidal one, and we'll get significantly more parking spaces as a result of that. They, in return, foresee a time in the not-too-distant future where they would like to build a similar structure and have the same constraint. And we've agreed that we would let them build on our property like they're letting us build on theirs. And in addition, as part of the parking structure, there will be an office built there for BART to use. And I think that the two agencies working together to share their resources will benefit the public. And it's a win-win.
For both agencies, and it was really nice to see the additional parking spaces that we'll get out of this. I know those will be well used.
Well, I think construction on the parking structure will start pretty quickly once we get this agreement inked.
Good. Well, let's get this rolling then. Now, all in favor?
Aye.
Aye. Any opposed? Motion passes. We have our agreement. Item C.
Mr. President, on April 25th, 2012, the Board of Directors of the district approved resolution number 1117, which authorized the Chief Executive Officer to enter into a joint powers agreement with the County of Alameda and to form the St. Rose Transition Authority to provide a mechanism for the district and the Alameda County to collaborate to support the continued operation of St. Rose Hospital and its related entities. On July 29, 2013, the Attorney General...
January 29th.
Oh, I'm sorry. On January 29th, thanks, 2013, the Attorney General of the State of California issued her conditional approval for Electo Healthcare Services Hayward, LLC, hereafter known as Electo, to enter into various agreements with St. Rose, under which Electo would manage St. Rose and have the option to acquire the assets of St. Rose. Given the Attorney General's approval and Electo's continued operation of St. Rose, the board has determined that the authority is no longer needed to support the continued operation of St. Rose, and therefore the district should exercise the district's option to terminate the authority pursuant to paragraph 4.2 of the Joint Powers Agreement establishing the St. Rose Transition Authority. I move for adoption of Resolution 1134, authorizing and directing the Chief Executive Officer to sign the Notice of Election to terminate Joint Powers Agreement establishing the St. Rose Authority. The Chief Executive Officer is authorized and directed to deliver the notice to Alameda County and to take any and all further actions necessary, which in the determination of the Chief Executive Officer incorporate the substantive intent of this resolution and to perform any and all other actions contemplated by this resolution.
Thank you, Mr. Wallace. Do we have a second?
Second.
We have a second from Dr. Stewart. The landscape has changed,
Yes, it has.
and our Joint Powers Authority is no longer needed, as Electo has taken over operations of St. Rose. Any other comments you wanted to make, Nancy, about this?
I think it speaks for itself.
Yeah. Great. All in favor?
Aye.
Any opposed? Motion passes. Item D.
Mr. President, I move that the Board of Directors adopt Resolution 1135, authorizing the incorporating of the Memorandum of Understanding in their entirety, effective on the various dates specified within the agreement between the Washington Hospital and the Professional and Vocational Employees Division Teamsters Union, Local 856, a recognized majority representative under the terms of Board Resolution 331A.
Second.
We have a second from Dr. Stewart. Nancy?
This is a contract which has been ratified by Local 856. The negotiations began in November of 2012, and meetings were held on November 19th of 2012 and also December 5th of 2012. The term of the memorandum is September 1, 2012 through August 31st of 2015. It's a 3-year contract. Contract was negotiated with no reopeners. This agreement covers 155 employees who work mainly in the admitting department and medical records departments. This contract provides for across-the-board increases, a 1% for all classifications as of September 1, 2012. So there'll be retro checks that are developed as a result of this. 1% across the board for all classifications as of March 2013, and again on September 1st of 2013, and another 1% September 1st, 2014, and 1% March 2015. The key contract additions include a clarification of seniority language, whereby the date that one is hired by the hospital shall also serve as the date in which one can exercise their union seniority. There's a clarification in the holiday scheduling, whereby both per diem and benefited employees must work either the Christmas or New Year's by rotation each year. That's one of the things I think people forget about. Hospital employees were open 7 days a week, 24 hours a day, and our employees do have to work during holidays. A clarification of the per diem pay related to a former benefited employee who's rehired to work as a per diem. And that language straightens out the technicalities of that. And there is a clarification in this contract of the tandem benefits language that relates to the board policy of tandem parity in 331A. So that is what's being proposed. It has been ratified by the employees, and I would recommend to the board that they approve the contract.
Successful conclusion. Any other comments or questions from the board? Then we'll call the question. All in favor?
Aye.
Aye. Any opposed? Motion passes. Do we have need for a closed session?
Yes, I do.
Okay, so we're going to adjourn to a closed session. We're going to reconvene to open session and announce that no action was taken in the closed session. And there being no further business, this meeting is adjourned.